My name is Dexter Hadley. I'm a physician and a scientist in Florida. Please don't hold that against me. And I'm going to tell you today about leveraging voice technologies on the blockchain to decentralize clinical trials. I have a lot of conflicts of interest, but this is a short talk, so we don't have time for that. So I hope to convince you by the end of this talk that, one, clinical trials recruitment is pretty biased, at least in America, and two, we hope to improve that with some technologies on the blockchain. So this shows a cumulative distribution of patients across ethnicity in America. America's a pretty diverse place, and it's pretty obvious where the enrichment is in European-derived patients compared to everybody else. Not surprising. You can take it down to the phase level, phase 1, 2, 3, and 4, and what I want you to point out here is, phase 1 is no efficacy, and if you notice, European-derived folks have the lowest phase 1 recruitment, but everybody else has much higher phase 1 recruitment. So it's a very dubious pattern. So we're talking about clinical trials, we're talking about voice, and I think the current state of the art for voice tech in medicine is this. Who is scam likely, and why are they calling me? I have an 85-year-old mom with Alzheimer's, and generally they're calling me to enroll her in Medicare. So it probably works really well, and they got a lot of people enrolled in Medicare, but hardly directly involved in their health care. We're in the age of apps. There's, a couple million apps on the App Store these days. If you search up breast cancer and look for clinical trials to sort of manage these problems, this is the best app going on right now. Belong Beating Cancer, 2.5 thousand recommendations. Apple has a privacy report now. And what's reassuring is identifiers and diagnostics are used in this process of matching patients to clinical trials. The panel before was talking about cancer and AI, and there is no AI at all in this clinical trials app. It's essentially a forum of humans that talk to each other, right? So you can go through the steps, which I find quite interesting because the first step of cancer diagnosis, be it prostate cancer or prostate is a PSA, but breast cancer is a mammogram. And nowhere in this app do you see any mammograms, right? So we're going to start with mammograms. Much like prostate cancer, there's an overdiagnosis problems in breast mammography because of mammograms, right? So in America, the FDA regulated mammography in the 80s, right? So if you regulate mammography in the 80s to catch small and precancerous lesions, you'd expect large and metastatic cancers to compensatorily go down. What do you see? You see small incidental cancers going up, which is an overdiagnosis problem without really the benefit we expect at the public health level. So to investigate that, I pulled a bunch of data from my last institution, University of California, San Francisco. These are all the mammograms. So basically, there are 5 million records in the radiology EHR system there, as in records. These are text documents associated with many images. So from 5 million records, there are about 800,000 images. It's actually more than that. I had 1 million images. Can anybody explain what happened before 2003, 2004? Why the graph is flat? This has been regulated since the 80s.
No age.
Film. And they didn't digitize it. So we have basically 1 million digital DICOM files. If the radiologists in this room would know, DICOM is a standard for radiology. Just laying around a PACS system in the hospital. We downloaded them. And what we want to do is basically reduce that overdiagnosis problem, or that was the intention. Except nowhere do you know if that radiology is positive or negative for cancer. That definitely is not in the PACS system. That's in a radiology report, of which we had 166,000 based on 43,000 patients. And for a subset of those, there's pathology reports, right? So the gold standard for cancer diagnosis is pathology. I'm a pathologist by training, and we had 33,000 pathology reports. So who's heard of ICD and CPT? ICD and CPT have very little to do with cancer, to be honest. There's no concept of recurrence. There's no concept of, essentially, all of the information we need is in these written notes that computers really don't understand. And our job is to read them, and for now at least, assign left and right breasts and positive and negative depending. If you read this, the lesion is in the left breast. If you read the right breast at the bottom after the mastectomy, it's not a cancerous lesion. So we did that on 10% of our data set. Remember I told you we had 33,000 pathology reports? This is the gold standard for cancer. We had med students and residents read about 3,000 of them, or 10%. And to make this a little bit short, since we have limited 20 more minutes, the government did most of my job for me. By regulating how breast cancer is charted and reported, we didn't even need AI to honestly extract the outcomes. So with simpler linear regression and, so this is just like logistic regression did the best to extract these outcomes. We published this a few years ago, just to sort of complete this part about the, training the AI to reduce overdiagnosis. This has nothing to do with breast cancer. This is in the medical record. It's to calibrate the machine. Nowhere is this written in the DICOM. We also train a deep learner to screen out these calibration images. And then this is a text. This is a talk about text, but we use the images and the labels that we inferred to show that we can actually train, so that we can actually train deep learning algorithms. We have 800,000 of these images. We've labeled them positive and negative. If in this little example here, we use a subset, about 12,000 images that we threw into a deep learner. If the labels were wrong, it would be a straight line. So the fact that it learns means my problem now is not the labeling, it's how do I deal with 800,000 images and petabyte scale data. Not the point of this talk. The point of this talk is now we can read clinical notes in real time and ascribe some kind of clinical algorithm to patients, right? So in this theoretical example, patient comes in January 1st. This is US style, so the month is 1st, with bilateral screeners. The guidelines are at 40, women go start their mammographic screening. So let's say first bilateral screener on the 1st of January. Again, we only care about pathology gold standard outcomes for the cancer diagnosis. Radiologist thinks it's suspicious. There's a diagnostic on the left breast a month later in February. That's also suspicious. There's a final aspiration the next month. That goes to pathology. The pathology is DCIS, ductal carcinoma in situ, pre-cancer. That's what you're supposed to find in the mammogram. By March, that's also suspicious. They do a lumpectomy, right? Lumpectomy is curative, and the pathology of lumpectomy is invasive ductal carcinoma, which is a progression of DCIS, maybe improper sampling, or the cancer progressed in 15 days, or whatever. So now we know what the cancer phenotype should be. We can go back and label the images. By August, the diagnostic on the left is negative. We could also label that image. So again, government, at least the US government, has done most of my job for me because we found it very easy to extract not just 1 and 0 cancer, not cancer, pretty much an entire ontology of cancer we could pull out of these notes because it's templated. Like every hospital templates these notes to avoid violating the Mammography Screening Act of 1980, whatever. So that's what we're going to talk about today. How do we work with language? Not only written language, but text language. This came out April 2022 in the New York Times. Should we trust what AI is saying? I think it depends. Like I said, government did most of my work for me. Logistic regression, equation of a line, I could extract these outcomes. When I moved to my current institution, which is University of Central Florida, we didn't even have a hospital. There are only 180-something universities, medical schools in America, and UCF is the 180th or something. It's a very new university. So we don't have a hospital yet. But what we do have is a bunch of med students, and part of our job is to teach med students how to chart and how to make notes on standardized patients. This is an example of a standardized patient note for standardized patient Clinton with abdominal pain, and it looks like that. Now the task is, we have 130 med students. You can imagine you have at least 10, 20 standardized patients. You're talking thousands of notes of some highly educated educator's time. Can a computer read that? Now that's not logistic regression. The government's not going to help me here. Beyond that, there's a rubric for how you grade these things and a standard that's accredited by the LCME, and it's pretty standardized. So obviously the answer is yes. Using the same type of algorithm, not logistic regression, we built our own natural language processing, or natural language understanding more so. So the idea is, can we transform words into some embedding space that makes them semantically related, right? So if you take the words chest, abdominal, nausea, and heartburn, you guys have heard of GPT-3? GPT-3 is the massive NLP engine, published papers in the New York Times and various places. GPT-3 is trained on the New York Times and trained on the Washington Post and trained on just colloquial language. And if you put chest, nausea, abdominal, and heartburn into GPT-3, you get very little separation in medical jargon space. So we had to train our own model of GPT-3 so that we can get good separation to understand the natural understanding of this and grade medical students, right? How did we do that? We read 1,000 pages of 300 med school textbooks. So it's like the perfect med student using our own embedding space. A very similar GPT architecture, but we trained it on medical jargon. Obviously, well, not obviously, but so we have human graders and we have computer graders now. And you might have heard of 𝐿𝐴 as a measure of inter-rater reliability. Any 𝐴 above 0.8 is pretty good, right? So if we compare 2,000 examples in our data set here of computer versus human across 10 different standardized patients, you see almost everybody is above 0.8. What do you see? You see there's a cluster of either bad students or bad standardized patients down here that needs to be investigated. So instead of 1,300 records or whatever that needs to be read, you cut that down significantly using this process, right? So this is what we're implementing our med school now. As you probably know, med students are pretty alpha, and it's not so trivial to say a computer algorithm graded you. So we're working on that, but it does work. This is a talk about clinical trials. So, once we could read and understand and grade notes, clinical notes, we thought we could do the same for clinical trials inclusion criteria. Right? So there's there are 4 different models here of language. One is a pure statistical one, This is a little Google's uniform sentence encoder, a little bit AI in that one. And this is ours, MedBrain. It may be hard for you to see, but it should be pretty easy here that if you measure the error between the centroids, so you see the different colors, right? So there's different colors of clinical trials I extracted. And if you just project each of these dots is basically a clinical trial. And if you project that into 2-dimensional space like this, measure the distance to the centroids, i.e. the distance to prostate cancer and this cancer and that cancer, we have the least noise, which means our model performs the best. Better than Google, better than BERT, better than, well, we read 1,000 pages of medical textbooks, so you kind of expect that. So yeah, I trust what these models say, because then I don't have to grade 1,300 med school notes. Of course I trust what they say. For the machine learners in this room, there's supervised machine learning and unsupervised machine learning, and then reinforcement if you want to consider that. That's unsupervised. And the problem is that it's supervised. So these things learn what we teach it. So the question is, what are we teaching them? Well, to begin with, I think the entire model of deep learning in medicine is broken the way it works today, and I'll show you some evidence to the fact that Google, Facebook, Amazon, Microsoft, whoever, they go around and they buy up all these de-identified data sets of patients from various hospitals. Once you de-identify the patient has lost reconnection with that data, and for most patients, I guess that's okay, but suppose you happen to have that false positive or false negative mammogram, and you happen to have an unnecessary biopsy, unnecessary pain and suffering. You definitely have co-pays, it's America. And the reason I say Google, because Google always gets in trouble, so I wish that the British consortium was here, because they're always getting in trouble buying stuff from NHS, because that's the only place they can get it. It's not illegal, but when patients find out that you're buying and selling their data without their informed consent, through some BAA mechanism or whatever it is, they're not happy. So these things make the news for the wrong reasons. Happens in America too, Sloan Kettering. 2018 this happened, and this happened in my med school. New med school, new hospital. The Health Corporation of America made a deal with Google to sell de-identified records, and there was a big uproar, obviously. Reminds me a lot of how media was bought, well, I wouldn't say bought, but acquired before we had iTunes and Netflix and some of these streaming services, except we're not talking about movies and songs here, we're talking about people. This is not America, but does anybody have any idea who this is? Her picture hangs in the halls of Congress. She's Henrietta Lacks. Anybody knows what a HeLa cell is? That's her cells from 1950. And I mean, the point of this is procedures were not followed, and now the family is being sued so many years later. Nobody knew this lady. 1950, John Hopkins, she died of ovarian cancer, and her cells were immortalized. 70 different patents have been found on Henrietta Lacks' cells at least. Regeneron is founded on Henrietta Lacks' cells. Nobody knew about it till Oprah made a movie in 1997. And now, we'll see, but this is the guy that sues everybody for civil rights case, and we'll see what happens. Apparently, I was quoted saying, if you want to buy a kilo of cocaine, you do it behind closed doors. It's the same if you want to buy data from Sloan Kettering. Sounds like me. So why is that? I think the problem is centralization, right? Centralized stores of data, right? So the hospitals keep this data and they centralize the data. They keep it in a silo, and that's not good. That's not good for AI. That's not good for a number of reasons. You can read what we all know. But this is medicine. My PhD is in genomics and computational biology, and as late as 2011, this is what our scope of knowledge, it's genome, we know where it came from, we know the ancestry, and much of it is relevant to me, right? And most other people that get disease, to be honest. Because while 96% of sequence that we studied, that the NIH paid for, is European-derived, most of the disease is not European-derived. 40% worse outcomes in breast cancer in African Americans, 40% worse in stroke, diabetes, infant mortality, et cetera, right? So this makes no sense at all from an engineering perspective. NIH realizes that. They're our main funding authority. NIH is a $40 billion operation, and they thought it would be a good idea to go around paying money to make data sets more diverse. And private entities are getting into this game now, signing BAAs with different healthcare providers. 20 different medical providers across 42 different states now have contributed to this data lake, let's say. Except it's the same problem, right? And what's the problem? The problem is, patients go to doctors write some stuff in the notes, and scientists that have access to said notes, that's where they get it from, except if you're a patient provider in a capitalist country, why would you give away your IP? Why would you give away your patients? You wouldn't. You wouldn't, despite what the law says. You probably can't see, but let me move this. But I think a better way would be to use the mechanisms that we have. So since the 80s, HIPAA has been around, giving us specific instruments to contact patients. I have no idea why there are few informed consent studies to actually contact the patient. I guess it takes time and effort, it costs money. But if you had informed consent, patients could sign up for themselves to get access to their data. That's what the law says. Since the 80s, there's another one called the Electronic High-Tech Act. So between those two laws in America, you can get the data with informed consent and HIPAA release. Except nobody takes the time to do that, except me. Right? So when the NIH goes around and amalgamates all these data, they just amass type 1 and type 2 error without having any concept of what that error is, how much it costs to correct, or what the effects are in the AI, right? This is entirely wrong, right? So I have a degree in engineering too, and it seems like an engineering problem that they're trying to pass off as medicine. Well, medicine has to involve the patient. It should involve some med schools. There are only 180 med schools, and not one is really teaching AI. So this is the point. We want to teach AI in our med school, sort of hands-on experience. To graduate in our med school, you have to do some kind of research. When I moved, it was 3 months before COVID, there was no way I was getting mammograms or studying mammography because mammography was shut down. So we studied COVID like everybody else. I ran a human subjects IRB-approved study asking 3 very basic inclusion criteria questions. Are you at least an adult? Have you been tested for COVID or diagnosed with COVID, and did you get an x-ray to work up that diagnosis? Just to see what happens, right? I put it in clinicaltrials.gov. It's still there. And the point is, if you want to get your image back, instead of these apps that just give you a equivalent Facebook without much more, we'll send it to you in an app like this, some URL by email. This is a company called Teleray. We launched ads on Facebook that look like this, pretty generic. We got 48 responses over 7 or 8 months. It cost me $7,000. We had 4 forms: enrollment, informed consent, HIPAA release, imaging, and you see the Facebook costs. $7,000 for 48 responses. It's not bad. When you look at the ethnicity of responses, it's more of the same. It's a big pizza pie, right? With one slice missing. Now, I don't know why men don't sign up for this, but it behooves me that I'm interested in breast cancer because women like to sign up on Facebook, so that's good. The one black man that signed up is my dad. He has since passed away, so he doesn't count. So it's infinite. No black man signed up and one black woman signed up. And this is kind of what you expect. This is how America is. If you extrapolate the cost for that $7,000, to sign up one white woman is $182 versus $9,000 for a non-white, for a minority patient. That's striking. And that means even if the AI did work, it's just going to scale the inequity in our system today. It makes no sense to expect AI to do anything in medicine except mess it up today, right? If you ask me. I wrote about this in Harry Popper's book, and yeah. So now we get to how do we fix this problem. I think transparency is a problem. I think being able to reconnect with the patient is critical because once you de-identify data, that data is lost to the patient, and there's never any. Imagine if you can re-identify the patient. There's no way in America you can have 96% of anything being sequenced if people actually knew what was being sequenced. It's not possible. People get upset for mass in America, right? So it's just not possible. So the blockchain can fix this, I think, by keeping the data federated, and the model can go around. On the blockchain, the parameters of the matrices or whatever. I've been saying this for a while, since 2018 at least. And this talk would have been much shorter if Elon Musk didn't go ahead and buy Twitter. And this is a great example of why we need to decentralize assets, essentially. If you remember, $7.99 to get certified. This was October 27th. The bird is free. Soon, Tony Blair and George Bush were reminiscent about killing Iraqis. This is fake. Eli Lilly, insulin will be free today. That's fake. This one is my favorite. Nintendo of USA, with a big you-know-what to Elon Musk. I mean, Elon Musk literally has the power to take down Twitter. This is government record. This is crazy. And, you know, what I found really interesting, there was a big efflux from Twitter to a decentralized service called Mastodon. I didn't really know about Mastodon, but I, too, joined Mastodon. And apparently, Trump tried to take over Mastodon about a year ago. So what is Mastodon and why are people moving to Mastodon? Because Elon Musk can't take down Mastodon. So Mastodon is a federated Twitter, essentially, meaning there's Mastodon at AI for good. There might be Mastodon at AI for bad. There might be Mastodon at I love cheese. Everybody can run a server for whatever you want. Breast cancer, sure, we can run a Mastodon breast cancer server. And each server is relatively independent. They can have their own rules. They can have their own guidelines and whatever else. And what makes this work is the blockchain. Everything is distributed. I don't think I need to explain how that works here, but there's services built on this blockchain. So this is what the Metaverse is. Mark Zuckerberg wants a little service up in there. But now we have decentralized YouTube, PeerTube. We have decentralized Twitter, Mastodon, and a bunch of other ones. So we built a decentralized stack to do exactly this for breast cancer patients. And since I'm running out of time, we don't really have time. But what this does is it allows microservices to be served. Each of these was what I call a microservice. It serves at least one human and either another human or an AI or something that interacts to serve that human. So voice, to me, is another microservice, right? So we heard yesterday from John Stein how voice can be used, obviously to service patients, but to authenticate patients just based on their voice prints. Right? Biomarkers for mental disease, the cough for COVID. We heard all of these examples yesterday. And in a decentralized world, we can do this. So let's get back to the clinical trials since I'm entirely out of time now. So, no surprise, cancer oncology trials are also biased. How about we have calls to enroll people in these clinical trials? Instead of the crank calls that, for Medicare and Medicaid, we can have, if we build this decentralized system and we have patients sign up, we can have calls to kind of recruit patients into the system. And beyond that, we have partners in Miami that have AI completely chatbots to take a full genetic history. I mean, can you imagine how powerful that is for breast cancer patients? And we're working with them, and our med students are working with them to show that this is actually accurate. I honestly don't know as yet, but it seems very feasible, right? Very, very feasible. So, we think voice AI can make clinical trials matching smarter. And just to finish it up, ICD and CPT, there's no concept of recurrence in ICD and CPT. There's no concept of fail the clinical trial in ICD and CPT, right? So post-COVID, communities have come together to extend ICD and CPT to represent these computable things. And the idea is, a patient's history for breast cancer could look like this, and it all can be represented discretely in computable forms like ICD and CPT. So if we apply our model, which we think is the best, to clinicaltrials.gov, if we apply it to patient records, we can help route the patient through the recommended algorithms. Once you hit 40, what's the next step? If you're African American, you get MRI, so on and so forth. But the point of 𝐈𝐶ode is really to match the clinical trials, right? So if you just follow this, the EHR, the same kind of thing I showed you, there are these standards, they get matched to 𝐈𝐶ode and they get sent to a trial service. This is a completely manual service today, that trial matching. So our idea is an example of a trial. There's 11,000 breast cancer trials at least, probably. I mean, it keeps going up every day. And this is what we're matching. It's pretty complicated, at least for the average breast cancer patient. Not so complicated for the average med student. So what we're going to do is have our med students segment these words and learn sort of the 𝐈𝐶ode profiles so that we can map all 11,000 breast cancer trials and all 100,000 or whatever it is, cancer trials to 𝐈𝐶ode. This makes it quite matchable and open source it to make clinical trials interactive. The engineers in here might have heard of human in the loop, active learning. I want to put our entire med school in the loop of this process so the students learn the subtleties of how this is going to benefit or hurt their patients. I think it's critical if you expect AI to make a difference, at least in America. And ultimately what we want is authentication on the blockchain, not the data. I don't think that makes a lot of sense. The hospitals hold on to the data. The law says we can get the data anytime. Apple iPhone has a whole service to get data. I'm 3 minutes over. But you can imagine, we want images on this system. We want clinical trials on the systems. We want clinicians through an NPI number we can validate, and we want patients. 1 in 2 women get a false positive. Where are they going to, when you get that mammogram and you get that false positive, what are you supposed to do? Put it on Instagram? Absolutely not. You should put it on a system like this that is HIPAA compliant. And just to kind of wrap this up, this was the AI BC, right? There's AI and blockchain involved in this. So here's an example of NFTs being used to celebrate achievement. So this was an EHR. This was an emergency worker that served in 9/11. They issue these NFTs to everybody that served in 9/11. These are verifiable facts, and you save on your insurance or whatever for these NFTs. We want to do the same thing for breast cancer. So you're false positive, we could issue an NFT. You failed clinical trials, you had a recurrence. All of these are NFTs that are anonymous, but tied to a patient, and if you have the keys, if the clinician has the keys, they can directly access that patient. So it puts the patient back in the loop in a very interesting way. And it's not just me saying this, right? So 2 weeks ago, NBC did a write-up on all these missed cancers in an Arizona hospital. My friend Beth Dupree was the surgeon that pointed this out and quit her job because of it. And with that, I'm 4 minutes over, but thank you.